Hi, everyone. I'm Dr. Samantha, the maternity mentor, and welcome back to another one of our live Q&A sessions that we have every Monday night here at 9 p.m. Eastern Standard Time. This is our opportunity to ask any questions that you guys may have left us on the videos this week. This is also your opportunity to get any of your questions answered live. If you have any questions, please feel free to put them into the chat and we will try to get to them during tonight's discussion. Remember, we have additional content on Facebook, Instagram, and Twitter. So we have those linked in the description. And remember, hit the like and subscribe button and the notification button so you can get notified when our latest videos come out. We have some exciting content coming out in the next couple weeks. And remember, share this family with your friends and family. Anybody who's expecting or has young children, they'll probably benefit from the content. So we're going to go ahead and we're going to get started with some of your questions tonight. All right, so we're going to start at the top with a formula feeding question. So this question says, which specific brands of formula do you recommend? Organic, gentle or sensitive, plant-based or goat milk-based? Which is going to be the most gentle on a baby's stomach for digestion? So this is a very interesting question that we're starting out with tonight. So as many people know, I am a huge advocate of both breastfeeding and formula feeding. I feel like it's important that babies get fed to parents' choice. And we should support parents no matter which option they choose or if they choose both, which is really cool because a lot of people think it has to be one or the other, and it can actually be both. When it comes to formula, I'm sure the reason why this viewer has asked this question is because there's like a billion formulas. And of course, we have a lot of international viewers, so this is going to be tricky to answer. So I'm going to start with the question of organic. So organic, at least in the United States, is kind of a controversial term. We think of organic as like all natural and, less chemicals, less preservatives, but that's actually not always the case. So organic has certain designations by law, but those types of produce, for example, can actually still contain certain chemicals. And not every chemical is regulated, which means there could be chemicals on an organic produce, or organic animal-based products like milk, that it's not actually organic. Okay. The other thing is organic is a labeling kind of process. There is like a system to being able to designate yourself as organic, but that doesn't mean everybody goes through that. And of course, these things are being spot checked. So I'm going to say that when it comes to organic, if you're going to spend the money on organic, you want to go ahead and invest in an organic formula that's a larger company, one that's probably being regulated more closely than, say, a small mom and pop. Now, the next thing that I'm going to say about organic is that there's been this craze lately in the United States for people here to want to go ahead and get formula from overseas. A really popular place to get formula from is Germany. So I'm going to tell you that this should not happen. Now, a lot of these people say to me, but Dr. Samantha, I've done all my research. This is a great company. Everything is great. It's fantastic. When you are purchasing a product that's being shipped across the sea, the first thing you need to understand is this product is sitting in cargo containers on big ships, sometimes for weeks or months. They are not temperature controlled. So all of this formula is being exposed to higher temperatures than what might happen in a normal shipping process that's a lot shorter. I'm not saying the trucks here don't have a high temperature in them, but it could potentially be in that high temperature for a much shorter period of time. The next thing is you can do all your research and you can think that everything is perfect. But I remember once taking care of a family in the hospital who bought special organic German formula because mom was not going to be able to breastfeed. They had it in the hospital, and our hospital protocol was that the pediatrician had to be able to see the formula and approve it. The formula they had purchased was toddler formula. It wasn't meant for newborns. And that was because there was a language barrier in ordering it. And then the other thing I've seen with some of these foreign formulas is that pediatricians go to approve it because a lot of times your own local pediatrician is going to want to see it, and everything's in a foreign language. So they can't understand the labeling to tell you if it's safe or not. So I'm going to tell you that generally speaking, you should stick to the formula that you can find locally. Now, the next question, gentle or sensitive? Well, this term is not necessarily two different terms. Depending on the marketing of a particular brand, it depends on, they could be the same thing. So regular formula is basically, for lack of a better way of putting it, like a whole molecule. And then these sensitive formulas tend to be a milk molecule that's broken down a little bit. Like the shells come off, so it's a little bit more digested, easier for baby to digest. Then there's even more specialized, more broken down formulas that are even better for babies. Now, a lot of people say, why don't I just go straight to the most broken down, most sensitive formula? Well, these formulas are super expensive. And as a result, if your baby doesn't need it, you don't necessarily want to engage in all this expense. The other thing is, as highlighted in the United States with the formula shortage, if your baby can tolerate regular formula, like they can just any bottle off the shelf, they're good to go, that can actually be easier for you, because during the formula shortage, a lot of parents whose babies needed very specialized formulas were not able to get it. And as a result, their babies were forced to be going to basically less digested or stronger formulas, like not as soft on the stomach, and their babies were getting very, very ill and were very uncomfortable. So you want to make sure that if your baby can tolerate like the most generic, like plain, like whatever it is on the shelf, that they should get that one. I don't necessarily recommend just going straight to the most sensitive. The last thing is, which is going to be the most gentle on baby's stomach for digestion? Oh, no, I'm sorry. Plant-based or goat milk-based? So generally speaking, plant-based is not recommended. Goat's milk is sometimes okay. You have to ask your pediatrician. It's kind of based on your baby's profile. Plant-based, most of the plant-based milks don't contain enough of the fat and protein that your baby needs, the growing brain needs, okay? And then some of those also contain, like soy contains estrogen. So it's not to say that your baby can't have them, but you do need to have a discussion with your pediatrician and make sure the baby's getting the whole total nutrition. And then finally, it's, which is the most gentle on baby's stomach? Honestly, again, technically it's the most broken down, but it's really whatever works for your baby. What I will finally say is that whether the baby's breastfed, bottle fed, or both, you want to ask your pediatrician about probiotics. So probiotics are kind of like a vitamin drop that contain the good bacteria that your stomach needs for proper digestion. A lot of babies, if given probiotics with regular formula, now you only give the probiotics once a day. Remember, babies eating multiple bottles a day. But that probiotic can actually help calm a sensitive stomach. And that may be all you need to keep your baby on regular formula. So that was an extremely good question. So thank you very much. And I see we have some questions in the chat. So good morning. Thank you so much for joining us. I see the question about vaginal discharge and its management. And then I also see, hi, Jennifer. So I see when I give my baby a bottle, she tends to drink it. Okay, good questions. Okay, so I'm going to start with vaginal discharge and its management. So there's vaginal discharge is normal during pregnancy. Usually normal discharge, you see I'm putting that in quotations, is kind of like a clear discharge. The idea is once you become pregnant, your body does start to produce a discharge that's going to help prevent bacteria from entering into the uterus. Okay, so you've got your vagina, you've got your cervix, the cervix leads into the uterus. Okay, and so we want to protect the uterus from infection. And there is normal vaginal bacteria that occurs, plus you'll be exposed to different things along the way. We all are every single day. When we start to look at vaginal discharge that might be abnormal, we usually talk about color. So we have white, we have green, and pink, and red, and brown. Those are usually your big colors. So pink, red, and brown, which we'll probably talk about a little bit later as well, those are usually signs of bleeding. So I'm not going to get too much into that because I'm probably going to answer some questions on it. But bottom line with those, you contact your healthcare provider because those are the different stages of bleeding. Now, white. Sometimes it's like a gray white. That can be an indication more of a sexually transmitted disease. Okay. And with our sexually transmitted diseases, we want to make sure they get taken care of right away because they're usually, a lot of them are fairly easy to treat, fairly quick to treat, and then that's better for mom and baby. A chunky, kind of thick white that's associated with itchiness is oftentimes yeast, which also is pretty easy to treat. Now, yeast is a fungus, so we use an antifungal. Most of the time, any over-the-counter medication that you can find for a yeast infection is acceptable for a yeast infection vaginally during pregnancy. However, you do want to ask your healthcare provider. Do not just assume you can use whatever you want. Some are creams, and you use a little applicator to insert them. Some of them are like these little, kind of like giant capsules that you can either insert with your fingers or with an applicator. Now, your healthcare provider may have a particular way that they want you to use the yeast infection medications, okay? And this could be in a variety of reasons, including if you're at risk for preterm birth and other things. So you need to ask them first. Additionally, if you've had one yeast infection and they told you to get this over-the-counter product, don't assume if you have this exact same symptoms that they want the exact same treatment. Because if you have an antifungal resistant infection, which means it's not going to respond to the regular medication, they may need to do something more intense. Now, when you're talking about that gray kind of discharge, it's usually treated with antibiotics. Same for those green discharges. If the green discharges, a lot of times they're frothy and kind of thin and watery. Gray and green oftentimes are associated with a smell, either just a not nice smell or a fishy smell. These are all signs of different types of sexually transmitted diseases. Now, some of them are just requiring an antibiotic. You just require an antibiotic. That's it. Some of them require you and your partner to be treated. There are different protocols depending on if it's chlamydia, gonorrhea, syphilis, trichomoniasis, bacterial vaginosis. It just depends on what you have. So how do they know? The way that they know is they need to swab you, okay? So if you call your healthcare provider, they should want to test that vaginal discharge. It's super simple. You go in, they take a cotton tip swab that's sterile. They go ahead and they insert it just enough to get some of those secretions, send it off to a lab. The lab tells us what that infection is, and we go ahead and we treat. Gonorrhea and chlamydia are always treated together, even if you're only positive for one. Now, why is it important? Let's say you have a little bit of discharge, but you don't really have any other symptoms. You feel fine. You just notice this discharge. Don't discount that. A sexually transmitted disease that's left untreated can lead to preterm labor, stillbirth, and miscarriage. Okay, some of these sexually transmitted diseases in the United States, we must test for either a couple weeks prior to delivery or at delivery if we don't have a result. Because if we don't treat a positive infection, it can lead to complications with the baby, including one infection causes the baby to go blind. So it is extremely important that we know what your status is. If you get treated during your pregnancy and your partner does not get treated, you cannot have sex again. Let me just say that. If your partner does not get treated for your sexually transmitted disease, you cannot have sex again because you will most likely get reinfected. If you and your partner had sex and that's how you contracted a sexually transmitted disease, then your partner is also positive. And without both of you getting treatment, you'll just pass it back and forth, and it's not good for your baby. So that's a very good question. All right, so Jennifer, I love this question. And we actually have a video on this, which is about paced bottle feeding, but this is how you do it. So when we take a bottle and we just pour it like this, the baby just chugs it down, okay? And all you hear is gulp, 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 and they're swallowing a ton of air. And what often happens with this also is that the baby overfeeds. And then the next thing you know, the baby's like spitting up and uncomfortable and gassy. So, what we need to do is slow baby down. So, there's a method called paced bottle feeding. And with paced bottle feeding, you hold baby upright and you hold the bottle kind of like this. So, a lot of people are concerned because if you hold a bottle like this, half the nipple is milk and half of it's air. And so what people are like is, oh my God, the baby's going to swallow so much air and then the baby is going to get gassy. But that's actually not the case. So baby's here, you hold the bottle up and you stick the bottle in and you let baby suck a little bit to understand that we're about to start feeding. And then you tip just a little bit and the baby will start to suck. And after like 8-10 sucks, whatever you want, suck, 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 you flatten it back out. This gives the baby a chance to kind of breathe and understand, or you can even take the bottle out and you keep this process going, but you're basically tilting like this. This bottle feeding method supports breastfeeding. Now, why is baby not getting a whole bunch of air? Because the baby, most of that air is coming back out of the mouth. As you're pacing, the baby's going to have a chance to take bigger breaths and like stop and like breathe. And so a lot of the air comes back out. What little air that gets swallowed is no more than a baby who's gulping down milk, okay? And we've all seen that. They're practically choking. It's coming out so fast. And you simply just burp the baby, just like you would before. Babies should do just fine with this. The other thing you can do for babies that are particularly aggressive is you can use the newborn nipples. There's different nipples that have like bigger openings as the baby gets bigger and can handle a bigger flow. A lot of people will use the newborn nipples longer, but this is sometimes some babies are able to get around it. That's why this method of paced bottle feeding, where you're kind of giving a little bit and then going back and forth, is actually a more effective method for going ahead and slowing babies feeding down. Let me see. If the test result is not available and we need, yes. Okay. So she's asking, so back to vaginal discharge for like a sexually transmitted disease. If a test result is not available right away, do we need to put the patient on antibiotics without a test result? So the answer is sometimes yes. In fact, I would say in a lot of cases, yes. When you're talking about this, most women are going to present to a provider who has experience. So given that you have experience, for example, there's this particular infection. Oh my gosh, I can't remember off the top of my head. I think it's trichomoniasis that's gray and it's got the fishy smell. It's either that or bacterial vaginosis. I can't remember right this second. But that one, it's very distinct. You see that color discharge with that smell, and you know that it's like 99% of the time this infection. You would go ahead and treat with the antibiotic you're used to treating with. Now, I'm going to tell you, most of these test results are coming fast, though. In fact, the chlamydia gonorrhea test, I think, is almost instantaneous in a lot of clinic settings because they want women who are presenting who oftentimes don't have access to healthcare to be able to get treated quickly. So in the same realm, if we suspect a infection and a woman might not be able to come back, we're going to get her treated right away. The other interesting thing, as I told you, partners need to get treated. Most often in medicine, if I see you, the patient, and you have strep throat, I am not writing a prescription for your spouse if they have strep throat, or your partner, or your child, or your mom who lives with you. Even though those people are probably most likely going to get strep throat or have it already, I can only write an antibiotic for you. In the case of sexually transmitted diseases, Most places will allow a healthcare provider to write the prescription for the partner as well, even if the partner is not present, because that's how important the partner gets treated. So that's a great question. So, my next question is about antibiotics. So, I am 35 weeks and my doctor has prescribed Curum 625 milligrams to be taken every 8 hours because after my urine culture, my WBCs, those are white blood cells, were slightly high and the test showed I had bacteria in the urinary tract. She's wondering if this medication is safe. So I'm going to actually tell you that as of right now, I'm going to see if there is a different name for this, but this particular medication is not available in my area by that name. And I'm going to look it up. So this medication is amoxicillin, which is safe for use during pregnancy, and clavulanic acid. So I want to see about the other one. So what I'm doing right now is I am looking up the medication. Your healthcare provider doesn't know everything under the sun. We all have references that we should be looking at to make sure that we are educating you properly. Okay. And so, one of the things I feel very strongly about is if you aren't sure your healthcare provider has done their due diligence, you can look to get a second opinion. Okay. So, the resource that we use here is a book by Thomas Hale, who's a pharmacist who has investigated all these and pulled a whole bunch of data together. Why do I mention him? He's a pharmacist. So, your secondary resource, no matter where you are in the world, is most likely going to be a pharmacist. Pharmacists have specialized training in drugs. So, if you ever want to confirm what your healthcare provider is telling you, your local pharmacist often can be that source. So, what this actually has said, once I looked at it, is because I needed to make sure the secondary ingredient was good, is this is safe for use during pregnancy. In fact, the only data it shows is that if you were to have a premature baby, there's a slight risk that that might upset the gastrointestinal bacteria of the baby, and the hospital might need to do something about that. But that risk is extremely small. And if you have an infection that needs to be treated, it's far more important that you treat that infection, because if left untreated, that can cause you to have a premature baby. So this is the biggest thing with antibiotics. If there's an infection, you need to be treated. You take all of the medication as prescribed. When we have an infection and we start to take medication, we often feel better in a day or two. Please do not stop your medication once you start it. That bacteria is still there in a day or two. The medication is making you feel better because it's killed a lot of it, but it hasn't killed all of it. If you don't complete the course of treatment, that bacteria can get stronger. And in a week or two, your infection comes back stronger. And then they need to use more intense medications in order to save your life and the life of your baby. So you want to make sure that you go ahead and you take all the medication as prescribed. Okay. And again, this medication is good for pregnancy. Now, she mentions that it's a urinary tract infection. So what you want to know is that urinary tract infections are one of the most common infections you will have during pregnancy. And they're one of the leading causes of having preterm birth. I've seen it over and over and over again. So if your doctor is telling you that you have a urinary tract infection, you want to take that seriously. You also want to make sure to prevent a urinary tract infection, which is one of the easiest infections to prevent. You drink lots and lots of fluids. You want to make sure you're going to the bathroom every hour, even if you don't feel like it. Don't avoid fluids at night because you know you're going to be getting up to go to the bathroom. That's not what we want. We want you peeing a lot because your baby is sitting on top of your bladder, which means you can't always empty it fully, and that allows for bacteria to grow. So make sure you're taking care of yourself and you're using the bathroom a lot, okay? All right. So, our next question is about postpartum hemorrhage. I experienced a postpartum hemorrhage with my previous 2 pregnancies. I'm having my 3rd baby this year. What can I do to try to avoid or minimize this? So, this is a great question. So, postpartum hemorrhage is one of the top leading causes of death after you have a baby. It's very, very serious. And I don't try to scare moms, but it is important that you take it seriously. And I think a lot of times we minimize stuff as healthcare providers. So, postpartum hemorrhage is where you start to bleed excessively after you give birth. Your risk of postpartum hemorrhage increases with each pregnancy. If you have a previous history of a postpartum hemorrhage, then you are more likely to have another one. So, this mom, unfortunately, coming into her 3rd pregnancy with 2 previous postpartum hemorrhages, she is at a higher risk. So, what can she do? There's not much you can do ahead of time. The only proactive thing I can tell you to do is to make sure you are not anemic going into delivery. So, anemia is where your red blood cells are low. And so, as a result, you have less blood volume and you can't transport oxygen as much as other people. Okay. So, how do you prevent that? You take iron. So, you cannot take too much iron. You need to be doing this with your healthcare provider. If you have too much iron, it actually can cause like iron toxicity, which is deadly. So, you need to make sure your healthcare provider knows what you're taking and how often. You want to take your iron with vitamin C. And when you do this, you need to take it at the exact same time. You can't take iron in the morning and vitamin C at night. That doesn't work. When you take iron and vitamin C in the exact same moment of time, whether it's an iron pill and some orange juice or whether it's 2 pills together, whatever you decide, that helps the iron absorb better. And you want to make sure you have as much as you can. Make sure your doctor is checking your iron levels to make sure you're not anemic in the couple weeks leading up to your pregnancy so you can prevent going in at a deficit. Okay, you want to be really good going in. Now, if you have 2 previous postpartum hemorrhages, I hope you're delivering in a hospital. I would tell any mom in the world who's had a previous postpartum hemorrhage, if you have the availability to a hospital, you want to deliver in a hospital because this increases your chances of, not. This is a way to save your life. If a postpartum hemorrhage happens, it's a medical emergency and it's a very quick medical emergency. Some of the things that you can do and ask for to advocate for yourself, ask for them to give you 2 IVs. So a lot of times you hear women saying they don't want any IVs. This is the little needle that goes into your veins so that they can give you medicine. Okay. They can hurt. They can be uncomfortable. It can be hard to move around with them. Ask for 2 because this is one of the ways that we can give you medication to save your life. Ask them to be giving you fluids. The more fluids on board, then if you do bleed more heavily, then that bleeding is counteracted with the fluid that they're giving you. You want to be well hydrated going into your delivery. A lot of times we want to give oxytocin or Pitocin. That's an IV medication, which during labor helps you contract. But after labor, it helps the uterus to contract back down and minimize bleeding. Ask them to do that. Make sure that's part of their plan. It is in most cases, but maybe at your facility, it's not. Or maybe in the past, you have refused it because you didn't know that that's one of the reasons it's given. It's given to prevent a hemorrhage. Ask them to make sure. Ask the anesthesiologist, that's the person who does anesthesia or like the epidurals and pain meds, what the plan is in case you bleed. A lot of people think the person who's going to be in charge of that is your OBGYN or your midwife. But in a lot of cases, the anesthesiologist has a big part to play in what happens next. So ask the anesthesiologist also about what the plan of care is. Sometimes when you're getting close to delivery, if you're in a hospital, they'll actually call for blood to be put into the room with you in case that hemorrhage happens. Okay. And then just be open to any of the medications. Unfortunately, other than that, there's not much else you can do. Most of the interventions come afterwards. You want to just monitor yourself. I want you to be open to treatments that they give. That's one of the biggest things that I see that happen is that women say, please don't give me a second IV, or please don't give me this medication. And that can make things harder. And any delay, even a minute delay, can be life-changing in the case of a hemorrhage, because you can bleed out half of your body's total blood amount in 2 minutes. So I want you to think about that. In 2 minutes, you can lose half of all the blood in your body. So if we can't get treatment on board fast, it can be your life. So the biggest thing is let them treat you and deliver in a hospital. The other thing is, when you have this discussion, you want to discuss with your partner, who's ever there. It can be your friend, your mom, whoever is there to support you during your labor. You need to express to them what your wishes are if you have a previous history of a hemorrhage. So in the case of this mom who's had 2 previous hemorrhages, she does have a higher risk. So she needs to let her partner know if she has an emergency and they need to bring her to an operating room to try to control the bleeding, whether she was there to begin with a C-section or whether it's a vaginal delivery that's turned into a serious hemorrhage. She needs to let her partner know if she would like a hysterectomy to save her life. If nobody knows the answer to that, they're going to do that to save her life. Period. End of conversation. It would only be if she expresses ahead of time that she does not want that to happen, that would be considered. The other thing is, you need to let people know if you are open to receiving a blood transfusion. Again, if your life is in danger and we think you need a blood transfusion, we're going to give it to you if we don't know the answer. In cases of religious exemption, they will try to explain to you the risks and benefits, even if you've previously declined, because they need to say to you, this is to save your life, and allow you to make that call. Okay. So that was a great question about hemorrhage. Okay. So I see Sashana, I hope I'm saying that right. 18 weeks pregnant, and your doctor told you to take 2 baby aspirin. Okay. So this is an interesting question. So I can't say 100%, but there's usually 2 reasons why baby aspirin is given during pregnancy. The first is because they're concerned that you're at risk for blood clots. So when we're pregnant, we actually have higher clotting factors in our blood. These are the substances that when you cut your finger, the blood, it stops bleeding almost right away. That's because clotting factors come here and basically like put a piece of tape on it from the inside to stop the bleeding, okay? These clotting factors are going to serve you well to help prevent a postpartum hemorrhage when you deliver. That's part of the reason why they're there, okay? We don't want to bleed out when we deliver. And even though most pregnancies will go to full term, which is 39 weeks or greater, the body kind of knows that it's a possibility you could deliver earlier. So they have these substances kind of already floating around, ready to go. We have them all the time. They're just increased. Okay. So it's possible, depending on a lot of factors, including your weight, that they may have deemed that you're a higher risk for developing blood clots, especially in your lower legs. Baby aspirin, when taken, will thin the blood to help prevent that. So one of the things you need to look out for is bruising. So a lot of people who take baby aspirin will bruise. Going along that same realm, there's been some research that shows that they believe some of the causes of miscarriage are associated with the placenta developing clots, or big areas that the blood can no longer flow through. So you have the uterus, and the uterine wall is full of blood vessels from your body. And the placenta attaches to that. Now, the placenta is the organ that the umbilical cord, which goes to your baby's belly, is attached to, and that's how your baby gets fed. So the blood flows in to the baby's system, which has in that blood from your body to the baby, it's full of nutrients and oxygen and everything the baby needs. And then all of the baby's toxins, the things that normally you and I will either pee or poop out, well, baby doesn't do that yet. So all those toxins come back out through the umbilical cord into our system through the placenta and the uterine wall. And then we filter it for the baby while we're pregnant. Now, that placenta When you go to see, and I would totally encourage all you guys to look at your placenta after you deliver if you're not going to get grossed out. So you have the one side where the umbilical cord comes out and the top of it's very smooth. It's kind of this shiny jelly-like look, and you can see all the veins and stuff. It's really cool. When you turn it over, so this is the side that was attached to the wall, it looks like ground meat. It is very like a sponge. It's like ugly. And that's because this was where all the blood vessels were that were getting all that blood. And so it's very porous, kind of like a sponge. And that was all open and raw. Well, if you have a lot of clotting factors here, and you imagine this to be a sponge, sponges have all those little holes in it, right? Well, if those holes have blood going through them, but the blood is clotting off, it's basically clogging it up, and then you can't get blood through that anymore. If enough of that happens, the placenta doesn't function well for the baby anymore. If you have a placenta that doesn't work well, you can get a baby who is IUGR. IUGR is intrauterine growth restriction. And an IUGR baby is usually smaller for gestational age, and they usually don't grow as well. So oftentimes we'll first notice this because the belly will be measured and the belly will be smaller than we expect it to be. Your belly size, they usually do with like a ruler, and it should be 1 centimeter above for like every week you are. So like at week 33, it should be 33 centimeters. So if we don't see that measurement and it's smaller, we'll do ultrasounds to check on baby. So if they're concerned about how your placenta is functioning and whether there's enough blood flow, they may be giving you the aspirin for that reason. Okay. So that's actually a very, very good question. And some moms, you cannot do this without the advice of your doctor, but some moms will even be told to do that before they get pregnant, depending on their health history. So that's a very good question. For those of you who are joining us, thank you so much for joining us. I'm Dr. Samantha, the maternity mentor. Welcome. We're doing our Monday live Q&A session where we're answering your questions from the videos this week, any comments that you made. And we're also, any live questions you have, please feel free to put them in the chat. That's what we're here for. You're so welcome, Shoshana. I hope I said your name right, and I hope that helped. And please, any questions you have, feel free. We're going to try to get to all of them. We have another question that is, was an interesting one that we got. And so this mom had a question about a very unique situation. So she had a question about, a uterine septum surgery. Okay. So basically her uterus was divided by a septum. So what's a septum? How do I describe this? So your nose, the inside of your nose, right? We have 2 nostrils. The inside of your nose is divided right here. And this is called your nasal septum. It's basically like a wall. Otherwise, this would be one big hole, right? So the uterus is like one big ball, right? Just it's open. In her case, she had a septum. So she had a wall down the middle, almost like having 2 uteruses. And she had a surgery to remove that wall. So she's now asking, what's the % chance of getting pregnant, and how many months later can I try to get pregnant? So unfortunately, this is not an answer that I'm going to be able to give her very adequately. But I'm going to take this and I'm going to apply it to all uterine surgeries. So there's many uterine surgeries that you may have besides this very unique situation. For example, you may have fibroids removed, okay? You could have a myomectomy, which is another type of surgery. You could have cancer removed. You could have one of your fallopian tubes removed. Every surgery is a little bit different. Usually, you can start to get pregnant as soon as you're fully healed. Now, in the case of a separate uterus where the septum is removed to create one uterus, this is a complex surgery that probably will require 6 months to a year of healing. Versus when you have a fibroid removed, a lot of women will be healed after 6 to 8 weeks. Once that healing takes place, you obviously have to talk to your healthcare provider who knows your full health history, but you may be able to start getting pregnant right away. Now, the percent chance, unfortunately, there's no way to know that. A lot of women want to know this answer. They want to know what their chances are of getting pregnant, but it's a very complex scenario. It's based on your nutrition, your age, your stress level, your job, et cetera, et cetera, et cetera. So there's no way to know for any of us what our percent chance of getting pregnant is. And then just remember, miscarriage is very, very common. 1 in 5, 1 in 6 women are having miscarriages. And we don't talk about it a lot because it is a very sensitive subject and it's very upsetting for a lot of women. But so many women have miscarriages, and so many other women have miscarriages that they never know about. A lot of women will get pregnant and go on to have their regular period, never knowing they were pregnant, because the body will try to prevent a pregnancy from maintaining itself if they sense there's any kind of genetic abnormality. And our bodies can sense that. So as a result, women have many, many miscarriages. And so that also plays into percentage, because your percent chance could still be very high, but it looks small because of that. But it was a good question, and I hope you are recovering and feeling better from your surgery. All right, so our next question is about depression. I'm pulling out my handy dandy guide, and this person is asking about citalopram, which is not one of my favorites. So I'm going to just check it out and see if yes. Okay. So let's talk about antidepressants. There's a lot of different antidepressants that we use during pregnancy. And for any depression, anxiety, you need to know that if left untreated, you have a higher risk of developing miscarriage. You can have preterm birth. You can have stillbirth. You can have babies that are small for gestational age, poor growth, babies that have trouble with their blood sugar. They have trouble breathing at birth. Yes, untreated depression or anxiety can lead to complications after birth for your baby. So it is important that to treat anxiety and depression if it's affecting mom significantly. Significantly is a subjective term, but it's actually better to use medication. Okay. There are some homeopathic things you can do, but medication is often needed. So normally, what do we start with? Zoloft. Why Zoloft? I prescribe it every day, day in and out. I can't tell you why. Somewhere along the way, some doctor decided to start using Zoloft, and then another and another. So Zoloft is not particularly special. I love it. It's a fantastic drug, but there's nothing significantly special about it over Lexapro, over citalopram or Celexa, which is what our question is about, over Prozac, over Effexor, over Cymbalta, none of that. It just happens to be the one that was used first. And when we saw that women weren't having complications, a whole bunch of people kept using it. So this is the one that we have the most data about, the most information, because you cannot do a study of safety on a pregnant woman or a breastfeeding woman for any medication. Lexapro tends to be the second one used. So, and then Prozac is number 3. Why in that order? I'm not really sure. I can tell you that Lexapro has a little bit less side effects than Zoloft usually, and Prozac tends to last in your system a lot longer. So if towards the end of your pregnancy, you wanted to come off of that medication before delivering, which some women choose to do, it's hard to get off of it in enough time. So the thing is, the question is about citalopram. So I checked my handy dandy drug guide because I don't ever like to 100% assume I know everything. Citalopram is safe for pregnancy when the benefits outweigh the risks. There is no indication that it causes any kind of birth effects. This is the big thing everybody's worried about. So what you need to understand is walking down the street, a healthy woman with a healthy pregnancy has a 2 to 5% chance of developing a birth defect spontaneously. Nothing could be wrong. There could be nothing going on, and you still have a 2 to 5% chance of developing a birth defect. Now let's talk about untreated depression and anxiety. Untreated depression and anxiety can actually increase your risk of certain birth defects as well as depression and anxiety. Now let's talk about citalopram, Zoloft, Prozac, Lexapro. If you use any of these medications, there is no indication that your risk of birth defects is increased. So not only is there no evidence that you will have an increased risk of a birth defect, you will actually be decreasing your risk of having complications for the baby, having a miscarriage, having preterm birth by treating your anxiety and depression. Now, another question people oftentimes ask is, how do you, besides Zoloft, because everybody uses Zoloft, how do you know which one to use? Well, one of the things we also look at is if you've taken a medication before. The evidence shows that if a mom presents and she says to me, I took citalopram in the past and that worked best for me, I'm not going to put her on Zoloft just because Zoloft is the one that everybody grabs. Instead, I'm going to use citalopram. Because if that worked for her, I don't have a lot of time in a pregnancy to mess around with meds. I need something that's going to work and work quickly for this patient, which is why we tend to go back to what's been used in the past if they have a medication and it is safe. Now, the other thing you need to know about depression and anxiety is we want to treat you until you feel better. We don't want to treat you until you tolerate it. So what do I mean by tolerate? So a lot of times when we're talking about pain medicine, we don't treat you if you use zero is at the 0 to 10 scale. 0 is no pain, 10 is the worst you've ever felt, okay? And somebody says to me, I'm a 6, I need pain medicine. I'm not necessarily trying to get them to a 0. If they just had surgery, they're going to have a little bit of pain. So I'm trying to get them to a 1, 2, maybe a 3. In the case of depression or anxiety, I don't want to get them to a 1, 2, or 3. I want to get them to 0. No depression, no anxiety. Why? The point of treatment is to eliminate the depression and anxiety. Because when you're depressed or anxious, your body is emitting stress hormones. And these stress hormones are affecting your overall health. They're affecting your circulation, and those two things affect the baby. The baby is also being exposed to those stress hormones through the placenta. So we want to eliminate that. And the best way to do that is to treat you to remission or where you have no more sense of depression and anxiety. Are we always completely successful? Not always, but we definitely can really get down there. And so if I have a mom who comes in at a 6 and I get her to a 1, that's a fantastic achievement, okay? But yes, citalopram is one of the medications we can use for depression or anxiety. Now, I have another question tonight. Lots of medication questions. So this one is about blood pressure. And blood pressure is an interesting thing because blood pressure is treated very, very differently during pregnancy. So let's see. Okay. How about amlodipine? I'm taking it and I'm 8 weeks pregnant. Is it safe? What should I keep an eye out for? Okay. So starting off, you do not stop any blood pressure medication. You do not stop any medication without talking to your healthcare provider. But you cannot stop cardiac medications. These are heart medications. Blood pressure is included in there without talking to your healthcare provider. Okay? Amlodipine is safe for use during pregnancy when there are no other medications that can be used to treat whatever your issue is. Amlodipine is not a common medication that's used. And because of this, I'm suspecting that there's a very specific cardiac condition that you may be experiencing, which is why it's being used. Amlodipine does have a very small risk of birth defects. Now, risk of birth defects does not mean guarantee of birth defects. It means risk. So that means that you could take it your entire pregnancy and never have a birth defect for your baby. But it is a medication that requires you to speak with your healthcare provider immediately to talk about risks versus benefits. Now, let me be clear. If you stop your medication and it causes a cardiac arrhythmia, that would affect the blood flow to your baby, which could cause a miscarriage. If you stop your medication and you develop high blood pressure, you could end up having a seizure. If you have a seizure, it stops blood flow to the placenta immediately. If the baby does not receive blood flow to the placenta, the baby will die. The baby will you will have a miscarriage. And I say this point blank because a lot of women, when they hear the risks, they want to stop their medication cold turkey, and you cannot do that. Those risks are far greater. So you want to contact your healthcare provider immediately at 8 weeks pregnant. You may not have even done that, or they may not know. They need to see you right away. You also need to contact your cardiologist if you have one, and you need to let them know that you are pregnant. And you need to be asked to be seen by a maternal fetal medicine specialist. So a maternal fetal medicine specialist is the doctor who takes care of high-risk pregnancies. These guys take care of everything, and they're the ones who know all the blood pressure medications best. If you have certain cardiac conditions, it is more important that you get treated, because if you don't get treated, you can't sustain the pregnancy. The blood pressure medications involve the circulation of your blood. And if your blood is not circulating properly, you can't feed the baby through the placenta. Now, as your pregnancy progresses, they may allow your blood pressure to go a little bit higher than you're used to. So what we're all used to is trying to get to low blood pressure. But when you have a placenta you're having to push blood through, sometimes that placenta will require a slightly higher pressure if you have high blood pressure to begin with. So your doctor is going to manage that very, very carefully. But again, if your blood pressure goes out of control during pregnancy, you can end up having a seizure. And a seizure is an immediate emergency C-section if you were inside of a hospital. Immediate. They literally put you to sleep and they take the baby out. And that's how much of an emergency it can be. So you need to be closely monitored. Now, are there other medications that can be used? Yes, and several of them are listed inside the video for high blood pressure medications, and we'll link that video into the chat. But every blood pressure medication, it comes in a certain class. So each of these classes, there are different sections of medication for blood pressure. Each of these classes works a different way. So one may not work for you or may not work for the condition that you have. And that's why it's important that you get on the phone immediately and contact your healthcare provider. All right. Remember, if you have any questions, please put them in the chat. We're kind of getting towards the end of our live Q&A, but I do have a couple questions about bleeding, and I'm going to kind of put them all together. So, because they're all kind of very similar. So my wife is 5 weeks pregnant with our first baby. Today, she got a few spots of blood in her underwear. It wasn't much, but she is so worried. Is it scary? The next question. Hello, I'm now 9 weeks pregnant. I have bleeding. Will this cause any problems? Please tell me. And the last one is a mom who reports that when she was 3 months pregnant, she almost had a miscarriage. And now she's 20 weeks pregnant and she's seeing light bleeding with cramps. What could it mean? So bleeding can be very scary. In the first trimester, which is the case of our first two questions, 5 weeks and 9 weeks, you can actually see bleeding for a couple of reasons, which are very, very normal. So, for example, you can see spotting or light bleeding because of sex. If you have sex during the first trimester, which is totally fine unless your healthcare provider said no, you can sometimes bleed because the vaginal tissue tears. This is because the hormones that allow you to stay pregnant, they thin out and dry out the vaginal tissue. So when you have sex, especially if you don't have a lot of lubrication, the vagina can tear. So use tons of lubrication and understand this could happen. You still report it to your healthcare provider because they want to potentially bring you in to assess you, check you, maybe do an ultrasound. Because some other causes of bleeding include something called a subchorionic hemorrhage, which is like this little tiny bleeding spot underneath the placenta. And we'll put a link for our video on that in the chat. But that little tiny bleeding spot, it can bleed out a little bit and then eventually clot off, and then you stop bleeding. And so this can be very minor. Also, the position of the placenta, if it's too close to the cervix, can cause a little bit of that bleeding. Now, as you get further along, the next question, which is 20 weeks, so she's now in her second trimester, she is having light cramping. Light cramping could be a sign of labor. So what happens with labor is you have the uterus, and at the bottom of the uterus is the cervix. Cervix should be long, thick, and closed. So you have this opening, but everything's closed. When you give birth, the contractions help pull the cervix apart so the baby's head can come down, okay? At 20 weeks, if you're having cramping, what could be happening is you could be starting to dilate. And as you dilate, one of the things that happens is we see a little bit of bleeding. When you're full term in the hospital getting ready to give birth, we consider a little bit of bleeding normal. But at 20 weeks, the two things together would make me very concerned that you're going into preterm labor. And that's what I think would be the most likely cause. And you want to go ahead and you want to call your healthcare provider so they can check it out. So those are good questions. Okay, so I see Christopher has a question. Hi, Christopher. Welcome. If my partner has full-blown sickle cell and I'm a carrier, will the baby be born with full-blown sickle cell? I'm 14 weeks pregnant. Okay, so this is a great question. And the answer is most likely, but not 100%. So when you're in medical school, whether it's a doctor or a physician assistant or a nurse practitioner or a nurse, we learn about genetics. This is a genetic question. And there's this little diagram that happens. And what it is we all have genes, and genes are basically made up of two letters. So imagine for sickle cell, okay, that it's supposed to be two little S's. So two little S's means no sickle cell. You don't have the trait, you don't have the disease. It's just normal, okay? Somebody who has full-blown disease, they have two big S's. And somebody who has the trait has a big S and a little s. And what we do to determine the likelihood of the baby having that is we put mom and dad onto this little chart and we graph out those. And it sounds complicated, but it actually ends up being 4 boxes. The point of this is your baby has a 25% chance of coming out with no sickle cell disease or sickle cell trait based on the two of you having one with a full-blown disease and one with the trait. What'll happen is afterwards, they're going to go ahead and they're going to test the baby to determine that. Now, I noticed that you said that your partner is sick. Now, I don't know if what you're saying is that the full-blown sickle cell or is that she's also having symptoms. Make sure during the pregnancy that if she thinks she's going into crisis at all, any blink of a crisis, and sickle cell patients know that she goes to receive treatment. The other thing is hopefully her healthcare provider will help be an advocate for her. Sickle cell patients experience extreme pain. It is awful. And the way we treat it is with very heavy narcotics, okay? These are strong pain medications. And normally, most parents would not want to take these medications while they are pregnant. Now, these medications will be given in an IV. And if your partner has a sickle cell crisis, they're going to put her into a unit where they can monitor the baby. These medications will cause baby to be very sleepy. So they're going to do a lot of monitoring of the baby to make sure the baby and the heart rate will be normal, but a lot calmer. We like babies' heart rates to be all over the place. So it'll be calmer, and that is okay. Your partner should continue to receive medication if she is in pain. And I would say this for any type of pain when you're pregnant. If you're experiencing pain, this releases those stress hormones I was talking about earlier related to depression. And stress can lead to a lot of chemicals being exposed to baby that aren't good. Now, for sickle cell crisis, of course, as she's starting to feel better, we want to use the minimum amount of pain medication we can, but I don't want her to hesitate. The only other thing I tell my sickle cell patients is that You want to be careful if you're close to the end about using Benadryl if you don't need it. A lot of times we use Benadryl to counteract itching. Benadryl can dry out your milk supply. So I hope that answered your question, Christopher. And, if you had any other questions, finally, ask your healthcare provider to refer you to a maternal fetal medicine doctor. Again, those are the doctors that specialize in basically every complication during pregnancy. And they absolutely can do genetic testing and explain a lot more about the risks for your baby to you. Okay. They may even be able to, I don't know if it's around yet, but I'm sure they're working on developing a test while a baby's still in the belly to see if they have sickle cells. So I would ask, because genetic testing is changing all the time. So that comes to the end of our live Q&A tonight. I want to thank you all for being with us. Thank you all for the live questions. That's what we're here for. For any of you who are coming in, my name is Dr. Samantha. Hi, I'm the maternity mentor. Please check out our channel, like and subscribe. It really helps us out and we really appreciate it. And then also hit the notification bell because we're coming out with new content every week. We have a lot of exciting videos coming up for you. So make sure you tell your friends and family, follow us on Facebook, Instagram, and Twitter, and be sure to join us next Monday here live at 9 p.m. Eastern Standard Time, where we'll answer your questions from the videos, your comments from the videos, as well as any questions and comments you put in here. So without any further ado, thank you so much for joining us. I'm Dr. Samantha, the maternity mentor. Bye for now.